I'm Dr. Jitender Kumar Mokta, and I am Professor Internal Medicine, Indira Gandhi Medical College, Shimla. I will talk about the ST elevation MI. The latest WHO report says the most common cause of death in India is coronary artery disease. Near about 11.4% die in India everywhere, and India is known by the fact that the youngest coronary disease death, the sudden cardiac death in young people occur in India. It is the most the sudden cardiac death in young patient occur in India. It is the distinction. It is the highest number of the sudden cardiac death in the world that occurs in India. So I am talking about ST elevated MI. Now we have got a three-tier system in India. One is the tertiary care, where we have got angioplasty capable hospital. Second is intermediate, where we have got a thrombolysis capable hospital. And third is the peripheral, where we do not have anything except for Disprin. I call Disprin as a poor man's angioplasty. Why? Because when we give Disprin well in the time, it reduces the mortality by 25%. So I call it a poor man's one. So first of all, when patient presented because India lives in villages, so once the patient presents this acute coronary syndrome with ST elevated patient present in the primary care, present to the primary care center with the primary care physician with ST elevated MI, the first thing they should do is they should give 300 milligram of the sublingual Disprin. And second important aspect is they should not wait there. They should try to refer the patient as early as to the highest center. Now it depends upon what highest center is nearby to them, so that patient reach well in 2 hours, because the 2 hours is the time. That's a very important time. So the first thing is they should give 300 milligram Disprin, and they can't do anything else. Give them some sort of morphine as a painkiller, or if not morphine available, Contramol, and refer the patient within 30 minutes. This arrival time, this door to arrival time, referral time is very important. They should not waste the time for the more than 30 minutes there, because the patient should reach at a second center, that is a thrombolytic center, where the thrombolysis, we can give the thrombolysis well within the time. So he should or she should reach the thrombolysis capable hospital within 90 minutes. So once the patient will reach, the distance between the two should be like that. He or she, to get the maximum benefit, should be 90 minutes. Once the patient will reach at a thrombolysis capable hospital, that's a second tier system, the physician sitting there should not waste time. The door to needle time, again the door to needle means entering into the door of the hospital to the putting of the needle and giving the thrombolysis should be less than 90 minutes. Within 90 minutes, he or she should try to give the thrombolysis to get the maximum benefit, because once it is delayed, we may save the patient, but we may not save the myocardium. That's a very, very important distinction. So we should try to give the thrombolysis within 90 minutes of reaching to the hospital. And third phase is, even once the thrombolysis has been given, and then another scenario is that we refer the patient to the tertiary care directly, because it is nearby to that primary care center. And third tier system is where is the hospital where angioplasty can be done. So the referral time, after giving the 3 milligram of the Disprin, the primary care doctor should refer the patient within 30 minutes to the angioplasty capable hospital, and that is and he or she should reach there within 2 hours. That is the 120 minutes the patient should reach there. And if once the patient will reach there within 2 hours, the angioplasty team should be ready there, because the door to needle time again should be less than 120 minutes. Within 2 hours, the angioplasty should be done. And because this is why it is important, because if the angioplasty is done within this period, we get the maximum TIMI blood flow to the patients. Now we have got a scenario here. We have got a hospital that can refer the patient within this 2 hours to either angioplasty or your thrombolysis capable hospital. The preference should be given always to the angioplasty. Even after doing the thrombolysis, the patient should undergo angioplasty within 24 hours. Why? Because angioplasty has got better TIMI flow and better survival benefit as compared to thrombolysis. Why? This is very easy to understand, because once we give the thrombolysis, the chances of having the TME3 flow occurs only in 60 to 70% after thrombolysis, compared to angioplasty, where TME3 score is restored in more than 98% of the patient. So more than 98% of the patient has restored the TME3 flow compared to 60% in thrombolysis. And second, once we give thrombolysis, it only opened maybe 10%, 20% of the thrombus and in maintaining the TME3 flow. But once we will do the angioplasty, it will open the whole of the thrombus, because it is opening whole of the thrombus. The restoration of the blood flow is through the whole of the thrombus is opened up, compared to only 10-20% by the thrombolysis. So why this time is important? Time to referral, this door to needle, door to balloon time, because if we do not put this time concentration in our mind, we will save the patient. There's no doubt. We will save the patient, even giving it after that, but we will not save the myocardium. And patient is saved, but after 3 months or 6 months, he or she may present with your what you call LV dysfunction, what we call as cardiomyopathy. And we know the outcome of the cardiomyopathy in heart patient is as poor as that of the cancer patient. So time is muscle in this scenario. And third, I want to talk is about the infectious disease nowadays we have got. We are dealing with, at least in my state, we are dealing with this during this autumn season. We have given the epidemic of your dengue fever, the less common in Himachal, but we are more prevalent. We have scurf typhus, leptospirosis, and we are concerned with the enteric fever, and we are with the viral syndrome. So what has been seen in our personal study, again in IGMC, we see the most common cause in our state, like in many other states, is scrub or lepto and enteric fever. Though dengue is less common, more prevalent in Delhi and Punjab. So I will talk about the scrub typhus.